our team here a little bit. And the webinar started. I am Dr. Ravi Kohli. I'm the president of AAPI. It's my distinct honor and pleasure to invite Dr. Ramesh Adalja from Pittsburgh area to be the inaugural CME speaker. And like as I was mentioning earlier, he has an awesome, amazing background. I mean, I don't think I have met anybody with his kind of credentials and background. Like I said, he's not only an academic, he does clinical work every day, from what I hear, and he takes a lot of work. And I was just talking to a physician from Butler last weekend at the Heathrow Airport. He was mentioning how much work he does in the hospital itself as well. And he's a social influencer, he's a policymaker advisor, he's a healthcare advocate, he's an academician, he's a clinician, he's a one in all. And it gives me great pride and joy that one of our fraternity and of our group is in such a accomplished young man. And I know he doesn't admit he's young anymore, but he's still young compared to all of us. So anyway, without much further ado, I will let Dr. Srini Gangasani, the chair of CME, take over, and then Dr. Prasad Garimella, our moderator, to take over the proceeding. So thank you very much, Amish, for taking time from your very busy schedule to join us. And I want to thank Dr. Prem Kumar, our TAPI local chapter president, to introduce Dr. Amish to all of us. Thank you again, and have a great program. I'll be watching and listening. I'm in Rajma in New Jersey for another meeting, but I'll be watching and listening. Thank you.
Thank you, Ravi. Thank you for the great interaction and all the things you've already done as a president so far in a short period of 2 months. So for who you don't know me, my name is Srini Gangasani. I'm a cardiologist from Atlanta, Georgia. I'm the current CME chair. I was a part of board of trustees of AAPI and a convention chair 2019 and 21. This year for the CME is, as Ravi said, we have the privilege of Dr. Ramesh Adalja to give the inaugural talk. I think in the last 2 to 3 years with the COVID pandemic, I think AAPI has taken to these webinars and the CMEs to the next level with educating all of us during those difficult times when the COVID started, when the things were changing so fast. So I think we're going to continue with the same tradition of improving the webinars every month. I think we want to get more new information and the latest information from the specialists throughout the world. So it's a great, with the monkeypox thing going on right now, we thought it'll be a great idea to start our first CME seminar webinar with monkeypox information as well as just the COVID information, what is going on right now. So before I give it to Prasad, the moderator, I just want to introduce my CME team. My co-chairs are Dr. Krishnan Kumar and Dr. Brahm Sharma and Dr. Sundar Rao. And my committee members, Dr. Pankaj Vij, Dr. Leena Gupta, and Dr. Prabhakar Sharma Prabhakar. Board member is Dr. Lokesh Adera, and our convention advisor is Dr. Vemuri Murthy. We has a fund of knowledge and has been helping us tremendously over the last 1 month to get these things started. We also collaborating with eMed Events, which is our accreditation process company. So who are doing the eMed Events accreditation. So you all get an email from them. So you can save your CME certificates in the vault, or you can download from them from the email. So without further ado, I'm going to introduce Dr. Prasad Garimella, who's a good friend, pulmonary critical care medicine, sleep medicine, and he's Can you hear me, Prasad?
Yeah, I can hear you. Can you hear me?
So yeah. So without further ado, Prasad, take over and moderate the session. And thank you for all of you for attending today. And let's have a great session. Thank you.
My name. I know. Maybe you did earlier.
Good morning, everybody. I hear some.
I put my first name, last name. Yeah, the further you have to go to.
I'm sorry for the.
Vijay, can you mute everybody else except I think the panelists so that we can have the talk? While waiting, I just want to add one more. I think this year we wanted to extend these webinars to our Indian medical graduates, postgraduate students, medical students, and whoever want to join from our alumni. So for the next onwards, I think this year we are joined by some of the medical students and the postgraduate students. So please let your alumni know so that these webinars will be utilized by the postgraduate students as well as other fraternity from our medical schools. Thank you.
Good morning, everybody. Can you hear me?
Yes, Prasad.
All right, fantastic. Good morning. It's my distinct honor and privilege to moderate this session. Just a recap, and I think AAPI has done tremendous job in this last 2 to 3 years. It is in the war with humanity versus virus. We all were in the front line, and we had to go through a lot of stuff. Just to think about it, within the United States, we have 500,000 people lost their lives. And, we lost about 100,000 healthcare workers alone in the world. I mean, it's a tremendous, loss of manpower and loss of lives and so much of hardship that we went through. So I want to thank AAPI for this wonderful, wonderful series where they are kind of coming up, with the CME. So thank you, Dr. Kohli, and Dr. Gangasani for coming up with this brilliant idea. And hopefully through this educational series and the knowledge sharing, we all will be more committed and more empowered to serve more. And then all these lives that are lost will be meaningful. So we're going to learn from all this, whatever happened through the hardships, and be able to help more and more people. And before we start the program, I want to tell Dr. Kohli's, Ravi Kohli's, constant statement about this post-traumatic growth. So instead of, we had a lot of trauma in the last 2 to 3 years. And, we need to focus on the growth. And this is a wonderful example of putting that into action, that post-traumatic growth, whatever we went through. So, and today, I think, we have a wonderful world-renowned expert who works at Johns Hopkins University as an adjunct professor and a senior scholar. And I was just looking through his CV. It goes on for 5 pages, 80 articles written, and board certifications in three specialties, and being a pulmonary critical care and sleep physician. And they're all kind of coming together. But Dr. Adalja is first did his emergency medicine board certified, then critical care, and also in infectious disease. And he is a senior scholar at the Johns Hopkins Center of Health Security and an adjunct assistant professor at the Johns Hopkins Bloomberg School of Public Health. He's also an adjunct professor at University of Pittsburgh, and and an affiliate of Johns Hopkins Center of Global Health. His work is focused on emerging infectious disease, pandemic preparedness, and biosecurity. This is very, very apt for AAPI to invite him and learn from his expertise. So we all can be more empowered and, ready to take on whatever virus is. And for today's presentation, I think we are going to focus on the monkeypox and the COVID. I invite Dr. Adalja to give his presentation. The agenda is basically for 1 hour or so. He is going to give his presentation on these objectives to talk about the monkeypox and also a little bit about the COVID variants. Afterwards, we are open for the questions. And if anybody has any questions, feel free to write it on the chat box. We'll make our best effort to use the experts' time, and so that we can answer all your questions. Without any further ado, please, let's welcome Dr. Adalja.
Thank you for that introduction. Thank you for the invitation to speak. I think these are very important topics, and I'm glad that you're devoting time to them, because these are, I think, some of the most pressing challenges we faced in the last century when it comes to infectious disease emergencies. So as you heard, I'm a senior scholar at the Johns Hopkins Center for Health Security. That is a think tank that works on infectious disease, pandemic preparedness, biosecurity issues. And I've been there since I was an infectious disease fellow. And I've spent a lot of time thinking about the intersection of infectious disease and national security, how pandemics start, how to make the country, the world more resilient to these threats. And I do a lot of speaking and writing and talking about these issues. I do a lot of media as well. I'm also a practicing physician in infectious disease, critical care, and emergency medicine. I rounded this morning at the hospital, and I'm on call now. Hopefully my pager does not go off while we're talking, but it is something that I do a lot. I practice in the Pittsburgh area, but I also spent a lot of time in the Baltimore, DC area working on those other issues. So I'm going to share my screen now, and I'm going to talk first about COVID, some of the updates on the variants, which are getting confusing for people. And then I will go on to monkeypox, and I'm happy to take questions on any infectious disease topic throughout the talk. So everybody can see my screen. Just somebody nod so I can see one of the. All right. And there's my Twitter handle. If anybody's on Twitter, I'm pretty active on social media talking about infectious diseases. So I'm going to start by talking about COVID-19 variants. And I want to do it in a different way than most people usually do, where they first talk about all these variants and get you all the nomenclature of alpha, beta, delta, Omicron. But I think it's important to take a step back and understand, why would they arise? And it's really important to remember that the virus that causes COVID-19, SARS-CoV-2, is a coronavirus. And there are seven human coronaviruses that we know about, 4 of which cause 30% of our common colds. So all of us are always getting infected with coronaviruses, probably multiple times in our lifetime. And these viruses mutate in order to get around our immunity, in order to efficiently infect us. So when you see people surprised about SARS-CoV-2 variants, it shouldn't be a surprise, because that is a family trait of coronavirus, is to be able to reinfect us. And this virus was always destined to become an endemic respiratory virus that we all dealt with multiple times. The goal was really to make it milder, to get us more tools like antivirals and monoclonal antibodies and vaccines to be able to tame it. So I think that there's a lot of surprise over these variants, but it shouldn't be surprising if anyone understands the viral family from which it arises. So how do these variants arise? So there's a couple of things that happened during COVID-19. Viruses mutate anytime they infect somebody. They're always going to accrue new mutations. The more chance they have to infect people, the more they replicate, the more mistakes will occur, the more mutations will arise. Most of those mutations are not going to be advantageous, meaning that they're just going to die out. But some of them may give the virus new properties. And where do we see this unchecked replication? It's usually in a couple of places. Non-immune populations. We know that vaccines, especially early on, were very good at blocking infection. That's less so the case now, but unvaccinated parts of the world, that's a place where the virus can sort of experiment with different mutations and let Darwin's forces see what comes out. Immunocompromised individuals are another place. So a person who is immunocompromised may not clear the virus, and the virus may continue to replicate in them and have more and more mutations accrue. And this is something that was actually published at the University of Pittsburgh, where they showed an immunocompromised person generating many variants within them. And then there is this idea of a reverse zoonosis. So people probably know what the word zoonosis means. Zoonosis means an infectious disease that goes from animals to humans, like rabies is a zoonosis. But a reverse zoonosis is a disease from humans going into animals and then changing in those animals and then coming back into humans. We sometimes see this with MRSA. We see this with other infections where you infect your pet, for example. That's also a speculation for where some of these variants came from, especially Omicron. People are still unclear on where Omicron came from, and there's 2 competing hypotheses. One is an immunocompromised individual, the other is a reverse zoonosis. And we know that COVID is now in many different animal species, including almost all the deer, almost all the white-tailed deer in North America are infected with COVID, which is a surprise to many people, and people don't really understand how that happened. but it's also infected minks and hamsters, and dogs and cats and leopards and mountain lions. So it's a very interesting phenomenon, but there's some combination of this which is causing variants to arise. As I said, that reverse zoonosis is one of the leading hypotheses for the Omicron variant. And just put a list there of interesting animals that have been infected with COVID-19 that you might not know about. I think hippos, manatees, anteaters, those are interesting animals. I don't know how they get infected with the human virus, but they clearly are. It could be that they're exposed to wastewater. So when you think about a respiratory virus, what would mutations, what would they try to do? What would they favor in that virus? So respiratory viruses are much more efficient at if they're more efficient at transmitting, that's to their advantage. So in a respiratory virus, what you're trying to see, what you usually see is mutations that are favored are those that increase the inherent transmission, meaning it makes it more contagious. Maybe you have a higher viral load. Maybe you sneeze more. Maybe you have more coryza, something that allows the virus to get from person to person more efficiently. And part of that might be, maybe it doesn't make you as sick because now you're able to go about your activities of daily living and infect other people. The other type of mutation that we see favored are those that increase immune evasion, meaning that this virus is now very constrained. It has to get around immunity. People are 95% of blood donors, for example, have some type of immunity. So the population is very different now in 2022 than it was in 2020 when this virus first emerged. So immune evasion, if the virus is able to get around some of the protection of our antibodies, for example, that's going to be favored. Those are going to be favored viruses. And that's, I think, what you've seen with Omicron. What have they done to our treatments? What we had to do is shuffle monoclonal antibodies. If anybody's been prescribing monoclonal antibodies, you know that there have been a series of monoclonal antibodies that have come and gone as the virus's spike protein mutated away. We now only have one monoclonal antibody that's actually effective for treatment. We still have one for prevention that works, but only the Lilly monoclonal antibody bebtelovimab is the only one that works because the mutations have made those other monoclonal antibodies not work. And what we've seen is vaccine efficacy versus infection falter, meaning the vaccine is very good at preventing what really matters, serious illness, hospitalization, and death. But I think after the alpha wave, we started to see waning of protection against infection. It was still pretty high for the Delta variant, but with Omicron, the vaccine is not very good after a couple of weeks at preventing infection. Of course, it is incredible at preventing serious illness, but its ability to block infection has fallen with variants. And this is just a slide here to show you where the variants have gone. So we started out with this ancestral strain that jumped into humans. We still don't quite understand where. And it basically has, originally, the original strain actually mutated very quickly and got this mutation in it called D614G, which seems to favor transmission. And then we've seen successive waves of alpha, delta, and different Omicron waves. And you can see towards the right end of that, the right end of the graph there, BA5 has now become the prominent one. And I think it's the virus really being driven by evolutionary pressures. And there are many different types of variants there. So we talk about, the ones you see on there, alpha, beta, delta, all of those are very familiar to most people, but there are many other ones like epsilon and mu that never really took off or were geographic or were just in certain geographic areas. But we've had this march of variants. And you can look at, this is a genetic distance map. So WA1 is the ancestral strain. That's Washington 1 is what it stands for, where it was. And you can see that there's a whole new branch where Omicron is. And off of Omicron, you can see BA1, BA2, BA3, BA4, 5, 2.121, and BA2, which is very interesting because if you look where Delta was, you see on the bottom in the blue, most people thought that the next variant would come out of the Delta branch, but it was a whole new branch. And that's why there's so much speculation about where did Omicron come from? Was it in an immunocompromised person accruing all these mutations? Did it go into animals and then come back into humans? So this is still a mystery, but it's just interesting to see how different Omicron is from almost everything else that was out there. And we can see that, we started out with alphas way over there, and then we went from basically alpha to delta, which are total jumps. So it's very interesting to see how this virus is evolving over time, and it's become a science unto its own. And this is a more recent update to kind of show you what's coming. So right now I said BA.5 is the major variant that we're dealing with around the world. However, there are some others that are starting to pick up. A BA.4.6, you can see they're highlighted in yellow, that has some geographic spread, and then BA.2.75. This one has been called Centaurus. I don't know if that's going to stick, that name, but that's what people have called it. This is one that people are watching to see if those become the major new variants that take over. I think probably not BA.4.6, but maybe BA.2.75 may become an issue. Some of these variants are far enough away from each other that they don't really help you if you've been infected. So if you were infected with BA.1, you're probably protected against BA.2, but you're not necessarily protected against infection from BA.4 or 5. So there isn't quite that good cross immunity because they are pretty far in genetic distance in their spike proteins. What our antibodies target are fairly different. And when you try to see, you know, what happened in this country versus that country, it often has to do with the waves they had. In the US, we had waves of BA.1, BA.2, BA.2.1.2.1, and then the BA.4/5. So I think we're protected a lot against serious disease with that succession, but there are some places where they might have been skipped by BA.1, for example, and they don't have that immunity in the population. So that also explains why countries have done differently with these Omicron variants. This is a very busy slide, but the point is just to tell you that there are a lot of people out there tracking mutations. The way we track mutations for HIV is become, you know, that's its own almost subspecialty. The same thing is becoming true now of tracking mutations. And you can find these types of maps where they're looking at different amino acids and to see what the change was and how prevalent it may or may not be. And you can see these Omicrons, they are very similar to each other, but there are differences in some of them that are what are responsible for one being able to displace the other. So that was my little bit on variants with COVID. I hope that was helpful to understand variants. My goal there was to really set the stage for understanding how variants arise, why they arise, and what it means in the future, and really to understand what's going on with them. I'm just trying to get rid of this.
Hey, Amish, can I ask you a couple of questions before we move on to monkeypox?
Sure.
Sure. So how do these variants, is it still the surveillance of, about 10% of the samples that are tested? That's how we are doing it. Basic question is, how do we know the new variants are coming? Because most of the testing is done in the house at home right now, and there's less done or less number that is being done in the labs. So how do CDC or other investigation agencies, are they checking 10% of the samples to see what the new variants are going to be? How does that process work?
So that's a great question. And it is very true that the majority of COVID-19 diagnoses are now at home, which I think is a great thing. But one of the other aspects of that is that the samples that need to be tested to see if they're a variant or which variant they are, those need to be PCR samples. Those need to be sequenced and then the variant characterized. So what happens right now is the CDC does sample some of the PCR tests that are getting done. That's a minority of them, and obviously it's going to be skewed because there's a difference between who gets a PCR versus who's doing this at home. So it's going to be skewed to people who are sicker probably and get a PCR test at the hospital. So that's one way. So yes, we do undersample variants, but one of the other things we do is wastewater testing. So many municipalities now in the sewage are looking at coronaviruses. They're sequencing those coronaviruses to understand the prevalences of variants. So here in Pittsburgh, we knew that Omicron was here before cases were identified because it was already in the sewage. So a lot of the worry about home testing decreasing the information to public health is fixed because, or is not as much of a concern because so many people are doing wastewater testing now. And I think this is one of the great stories of the pandemic, is that we really have shown that wastewater testing can be very important to track infectious diseases, not only COVID, but flu, even monkeypox. They were doing wastewater surveillance in San Francisco. Also, polio, these vaccine-derived polio viruses were found in the wastewater in New York City. So wastewater sampling may become a major trend in the future when it comes to infectious disease situational awareness. So I think that's an important way that we learn about which variants are present and when they're coming.
few more questions, if you don't mind, because COVID is on top of everybody's mind, and they're seeing it. It's in the face right now still. That's why a lot of our audiences are all, majority of them are clinical people. And this is wonderful, because you have this wonderful, you have this wonderful expertise, being in the research side, being in the clinical side, ICU, you see the patients and outpatient. So this is a wonderful opportunity for us to pose questions and learn from the experts, being on the both sides, on research side and also clinical side. So as far as the vaccines are concerned, so given this variants, and then we may expect that we may run out of the Greek alphabets to name this COVID variants, or number them at one point. So what do you think is are we going to come up with this new vaccines constantly, or you think there is going to be a vaccine that will cover all the coronavirus vaccination?
So it's another great question. So there's a couple of things. So first of all, we have to first step back and ask, what is the goal of our booster vaccinations? Is it to prevent all infections, or is it to prevent serious illness, hospitalization, and death? Because if it's prevention of serious disease, our current vaccines that are directed against the ancestral strain are holding up really well. And really, boosters are benefiting only high-risk individuals. Obviously, we know that the current vaccine is not very effective at preventing infection against the Omicron variant. So if our goal is to prevent infection, then I do think we need to have updated vaccines. But I don't know so we don't know this. With flu, it's a little bit predictable, where you know when you need to update the vaccine, and most years you have to update it. But we don't know what that interval is for coronaviruses. Is it at once a year? Is it every 18 months? Is it less than that? Those are all important questions that need to be understood. We know that in the fall that we'll likely have some type of vaccine booster that's directed against one of the Omicron strains. This has already been approved in the United Kingdom, which is a Moderna bivalent vaccine against the ancestral strain and the BA.1 Omicron variant. We'll see what happens in the United States. And again, we don't have good clinical data to show how well that vaccine works against infection. We know that it increases your neutralizing antibody titer twice over the regular booster, but what does that mean clinically? These are important questions that need to be answered, I think, to help with our booster policy. But I think the overall answer is exactly what you said: universal coronavirus vaccines that are not variant specific, vaccines that maybe target SARS-CoV-2 and the other 4 coronaviruses that cause 30% of our common colds. And there are vaccines like that in early clinical trials, phase 1, phase 2, that's going to be, I think, where this goes. And there's also vaccines that you haven't heard about that maybe are administered through the nose or through the mouth. Those vaccines will provide more immunity in your mucosal area. Remember back from medical school, IgA. IgA is in your mucosal surfaces, that antibody. It's very important. But our regular vaccines, our injectable vaccines, don't give you much of an IgA response. And maybe that's why they're not so good at preventing infection when it comes to these variants. So there are nasal vaccines and oral vaccines that are also coming. So I think that we're only seeing the very beginning of what's going to happen with the COVID-19 vaccine space. And then lastly, interesting stuff with the Novavax vaccine was just approved. It just got approved as a booster as well. That is something which uses, it's a protein-based vaccine, so traditional in that sense, but it has an adjuvant with it, which boosts the immune system. And there is some data that mixing and matching mRNA vaccines followed by the Novavax vaccine as a booster might be a really good combination. So there's a lot of stuff that's going to happen in the next 6 months or so to help refine our COVID-19 vaccine strategy, but it's not quite all defined yet and hard to predict.
It may be a little bit old news, but the Moderna CEO said in United States, we will have a bivalent vaccine by the fall season. So you think that's where we are heading towards?
Yes, I think that Moderna will have a bivalent vaccine. It's unclear what Pfizer is going to do. So I think we'll have to see. I think Moderna is probably going to do exactly what it did in the United Kingdom, which was a BA.1 ancestral strain bivalent vaccine. That's likely what they'll do. I don't know what Pfizer will do. It's interesting because the FDA had advised those companies to make their boosters against BA.4 or BA.5, but Moderna did BA.1. So there's going to probably be some debate about how effective a BA.1 variant vaccine is against BA.4, BA.5. And we don't know if BA.4 and BA.5 will still be dominant in the fall. So there's a lot of open questions right now.
Dr. Dave has asked a question about how long after COVID infection should one get the booster or new vaccine when available? I know a lot of this data is on the CDC. Could you please answer that too, please?
Yes, so you have to, the only real reason you have to wait is so that you don't infect people when they're vaccinating. So we tell people, so when you're not contagious, you can go get your vaccine. That being said, I don't know how much of a benefit you get if you've just been infected, because you've got a lot of hybrid immunity. So it may not be something that's necessary. So I take it on a case-by-case basis that, you know, if you're just 11 days out from your infection, you probably aren't going to benefit very much from a booster because your immune system has already been primed and boosted by this infection. So I usually tell people to wait a couple of weeks till their immunity falls so that they actually benefit from it. But it all depends. My advice on people with boosters really is about high risk. If you're a high risk person, you should be up to date with your vaccines. If you're not high risk, I don't necessarily think it's as strong of a recommendation, because the boosters are really designed to prevent severe disease. And if you don't have a risk for severe disease, you don't really get much benefit from the booster. But technically, just you don't need to be contagious. You can't be contagious when you go to get that, but you can get it anytime you want. But I just don't know how much you benefit.
Wow, that's good. That's bottled wisdom. So very simply, if you are not immunocompromised, you could wait on. But if you're immunocompromised, make sure that you are up to date on that. Right.
Yeah, not just immunocompromised. If you're old, if you're obese,
right. If
you're diabetic, yeah, and it's not just, so it's any of the high risk conditions that we've identified. Those people, the boosters are very important, and they are under boosted. We've got a lot of healthy people that keep getting boosters, but we need more of the high risk people to be boosted.
Fantastic. I'm going to double click on the treatments before we go. So as far as the Paxlovid is concerned, we have the Paxlovid as outpatient, then you have the monoclonal antibody, at least one of them available at this time for this variant. And then for hospitalized population, we still have the remdesivir, the steroids, and then the tocilizumab, all that stuff. So, and you think that the remdesivir oral medicine is going to be coming up soon, because IV medicine is going to be a little bit painful for us to get as outpatient. And how is that treatment, outpatient treatment, predominantly moving towards, in your opinion?
So remdesivir is an IV formulation. They tried to make an inhaled formulation. It didn't work very well. And they are looking at oral formulations. I don't know what kind of a market it's going to have, because Paxlovid is so good. A 90% decrease in death and hospitalization in an unvaccinated population. Remember, that was unvaccinated people. So Paxlovid is very good. And there's really only 2 drug interactions that are problematic. So I think this is something that is probably going to be the dominant way that we treat this outpatient. We'll see. There are next generation protease inhibitors coming from GSK, from Shionogi, from Partis. There are companies that all are developing ones that maybe don't need the ritonavir boost, that have less drug-drug interactions, and maybe don't taste as bad as Paxlovid. Paxlovid tastes very bad. Patients don't like it and they quit because of the smell, the taste it leaves in their mouth. One other treatment that I would mention is also Evusheld. That is a monoclonal antibody that we give to immunocompromised people as a preventative. It is underutilized. So if there are doctors listening here, think about if your patients qualify for Evusheld. It is in plentiful supply now. It's a little bit, you have to maybe fill some forms out to get it, but it is important. It's underutilized and it does work. Those are monoclonal antibodies that you give as pre-exposure prophylaxis. You give those to high-risk people and it really works.
Fantastic. So I guess last week, New England Journal came up with this article that the metformin and other medications that we have been using has shown no effect at all. For the audience sake, I just wanted to double click also all these other medicines that were like, kind of re-engineered for reused, metformin. So I think that article is worth looking at for us. Yeah. Awesome. Thank you. Take over to the monkeypox.
Yeah, there was one question in the Q&A that I would just ask really quickly. What is the incidence of rebound after Paxlovid? I think we don't know. It seems to be maybe 1 in 5 at the high level, but there's rebound that we're finding with Omicron cases, even in people who don't take Paxlovid. So it's still unclear what's going on with Paxlovid rebound. So I just wanted to do there.
I thought the data was saying somewhere around 1% of the population, but I have seen a little bit more than that. Isn't it that the data is saying that rebound is about 1% after the Paxlovid?
something like that. But so there's symptomatic rebound, which can occur in maybe 1 in 5, 1 in 6 people. And then there's viral rebound where the test turns positive, which is probably around, probably 1 to 10% in that range. But it seems to be something that occurs even in people who don't take Paxlovid. So this could be because it could be a reflection of the person. Are they immunocompromised? Do they have high risk conditions? Or it could be a function of the, it could be a function of Omicron, because the earlier studies were not done with Omicron. Even Paxlovid studies were done with Delta, not with Omicron. And it may be something specific to Omicron. I think there's still a lot more to learn about rebound.
Fantastic.
All right.
Great. Thank you.
Okay, so now we'll switch gears to monkeypox. And this is a virus that I've been tracking for some time. It's a very interesting virus that's been on a lot of people's radar in my field, but obviously was, like many things, was underappreciated by the rest of the community and was thought of as a travel medicine oddity, but now it's a major issue for the world. So I'm going to take you through monkeypox, starting with the history, a little bit about the virus, some of the clinical features, medical countermeasures, and the trajectory of the current outbreak. So monkeypox might be something that many people hadn't heard of, but it really has been known to science since the 1950s. And it was discovered in captive monkeys in 1958. It's important that it was found in captive monkeys because that's where it got its name, monkeypox. But monkeys have nothing to do with monkeypox, just like, so it's a misnomer. It does not come from monkeys. It just happened that monkeys got infected. The likely reservoir, we don't know what the animal reservoir is, but it's likely squirrels or some type of rodent. So maybe it would be better squirrel pox or rat pox or something like that, but they don't know exactly which organism is the natural host of this virus. First human cases were noted in the 1970s. And I think it's important to think about this with smallpox. So monkeypox is in the same viral family as smallpox. And when they were eradicating smallpox, and smallpox was the only virus that had ever been eradicated off the planet. It was led by D.A. Henderson, who died 6 years ago yesterday. He was one of my mentors at the Center for Health Security. What DA did was they eradicated smallpox, and when they were doing that, they wanted to find any case of smallpox. So there was a lot of surveillance going on all over the world, and that's where they started to notice these cases that look like smallpox but were monkeypox. So that's when the first human cases were identified in the 1970s. Most cases occur in about a half dozen countries in Central and Western Africa. The DRC is the country that has the most cases, the Democratic Republic of the Congo, formerly known as Zaire. Also cases in Nigeria and places like that. As I said, we don't know where this comes from, but it is some animal to human zoonosis. And if you look at the history of monkeypox, before this current outbreak, most cases occurred in children because children were most likely to have some interaction with whatever animal species had the virus, whether that's a rat, whether that's a squirrel. Most cases were in children. And it wasn't very transmissible. The secondary household attack rate was only 9%, which I think still holds, meaning that this is not a very contagious virus. The household attack rate of COVID is around 40%. The household attack rate of measles, 100%. So this is not something that is very contagious. So when you read and hear about people scared about something in a daycare center or a school or whatever, just remember these household attack rates. This is not something you get very easily. We did have an outbreak in 2003. Some of you might remember it. I was in training at that time, and it was a very interesting outbreak. And I think it really showed how good we used to be at responding to infectious disease emergencies. This was linked to importation of African rodents. Some people had brought in Gambian rats. I'm not sure why you would bring in Gambian rats, but somebody brought Gambian rats and was selling them mixing them at a pet store, and they started to infect prairie dogs, another pet that some people in the Midwest have. I don't know why people have prairie dog pets, but some people have prairie dog pets. And they had about 36 laboratory confirmed cases, 3 with severe disease. All of these cases had animal exposure. There was no secondary spread. Again, showing you that this wasn't a very contagious virus. And at this point, they were very nervous because if this got into domestic animal species in the US, it would be something that would become endemic in the US, just like plague is now endemic in the United States because it is in our prairie dog population in the Western US. But there was no animal seeding. And I think if this was a perfect opportunity for this virus to establish itself in the United States, but it didn't, which is very interesting. And they used a first generation smallpox vaccine to vaccinate contacts. And that's something I'll talk about in a second about the different generations of vaccines, but there was no controversy of using the first generation vaccine back in 2003. And since that time, we've had some importations, travel related cases, but no other major outbreaks of it in the United States. So looking at the virus, it is in orthopox, it's in the orthopox viral family. That includes smallpox, as I said, cowpox, vaccinia, which is the vaccine that we use for smallpox. That's a large viral family. And there are two different versions of this virus, two clades. The nomenclature has just changed. It's clade 1 and clade 2. There was a move away from using those geographic terms. The Central African / Congo Basin version was more severe. That is now known as clade 2. Clade 1. Clade 2 is the West African strain. That is what's spreading in this outbreak right now. So, so we have a clade 2 virus, which is less severe than the clade 1. And I think that's interesting because we've had 0 deaths in the United States with over 10,000 cases in the United States. And there's only been a few deaths outside of endemic countries, some in Europe and a couple in Europe, and I think a couple in Brazil. So what is monkeypox in terms of a clinical syndrome? It's a febrile viral exanthem, which is a generic term, which just means fever and rash. It has a long incubation period, 9 to 12 days. So it's not something, so that actually is advantageous. And I'll tell you why that's advantageous to us. But 9 to 12 days of incubation, people develop flu-like symptoms, lymphadenopathy, which is something that's very characteristic of this virus. It was something that was often on infectious disease boards, the lymphadenopathy, and then the rash. Sometimes the lymphadenopathy can get so bad that people get airway compromise if their lymph nodes in their throat swell. It was often said that lesions were all the same morphology. So you'd have to differentiate it from chickenpox. And when you see chickenpox, everything looks different. One lesion looks like a vesicle, one is a papule, one is a pustule. With monkeypox, they're all supposed to look the same. But as someone who's been involved in the care of monkeypox patients, they don't always present like that anymore. Sometimes they can look a little bit more chickenpoxy than you think. It's not as easy as an ID board exam question when you have to do it in real life. So one of the most feared complications are CNS complications, where you can get meningitis, encephalitis. Some of the fatal cases that have occurred have had CNS complications. So keep an eye on mental status change. One of the things that's characteristic of this outbreak is proctitis. And I'll get into the epidemiology, how this seems to be very sexually associated. And we are seeing men that have very severe proctitis where they can't go to the bathroom, and they may not have any other lesions. They may not have the rash. The lesions may all be internal, or the inflammation may all be internal, and you only see it on a proctoscopy or colonoscopy. But this is something that's new, and I think it's important to remember. If someone has proctitis, ask them about monkeypox symptoms, and they may benefit from antiviral therapy. Many people have gotten turned away early on in this outbreak because they didn't have the rash, and they actually did have monkeypox, but they only presented with proctitis. Mortality has been said, if you look in a textbook, 1 to 10%, but again, I think that's not necessarily applicable outside of endemic countries, and it's probably a biased estimate from even in those countries because there's probably a lot of underdiagnosis, so you don't know the true denominator of infection. How do you diagnose it? You have to do a PCR of the skin lesions, which is a limitation because there may be people who don't yet have the rash, who come to you with flu-like symptoms, lymphadenopathy, but don't have the rash, and you have no way of testing them. So there is an effort to come up with saliva testing or blood testing that may be able to give you earlier diagnosis rather than the PCR of skin lesions. Now, I'm going to go into the countermeasures that we have. So one of the things, so we have 2 vaccines. The one you're hearing a lot about is Jynneos, but I'm first going to talk about ACAM 2000. So think back to your history. The first vaccine that humans ever developed against an infectious disease was against smallpox in the late 1700s by Edward Jenner. This vaccine was some version of cowpox, but we don't even know, the virus is no longer cowpox that's in that vaccine. So it's some other pox virus. We don't know which one it is, but it works. It is a 1-dose vaccine, and it has very strong data because it's the Jenner vaccine, and you cannot have any stronger data than the target of that vaccine no longer exists on this planet except for in storage vials. So this is better than any randomized controlled trial data that there's no more smallpox. So it works very well. However, it is a live replicating virus, and it has some contraindications. One of them is that you can't use it in immunocompromised individuals. You can't use it in people with eczema because the virus is given intradermally and it can spread in someone with eczema and be very progressive in their skin and be cause a serious infection of the eczema. Because it is a live vaccine, you also have to be careful about vaccinating someone if they live with an immunocompromised person, because they can then spread it to that person and it could be severe. It could cause severe reactions in that immunocompromised individuals, and this has been seen. So there is a risk-benefit calculation here. Lastly, I forgot to mention myocarditis is also something that smallpox vaccine can cause. It seems to be about the same level as the COVID-19 vaccines. So when you're thinking about ACAM 2000, you have a risk-benefit calculation, because if it's smallpox, you're going to use, smallpox is a disease with a 30% mortality, much more contagious. If there were a smallpox case in the United States or anywhere in the world, it would either be a horrible laboratory accident or a biological weapons attack. So that changes the risk-benefit calculation versus monkeypox, which is not a fatal disease, for which we have very little hospitalization. So because of that, Jynneos is the more preferred vaccine. And Jynneos was developed because people wanted an alternative to ACAM 2000, because if there was a biological weapons attack, how would you vaccinate pregnant women? How would you vaccinate the immunocompromised? So Jynneos was a secondary vaccine that the federal government invested in. And it uses a virus called MVA, which stands for Modified Vaccinia Ankara. So it's a Vaccinia strain like ACAM 2000, but it's modified. It's not replication competent. It's not a live, it's not the same, it doesn't have the same replication that ACAM 2000, and it is safer. One of the drawbacks is it's a 2-dose vaccine, although there is some data on single doses. So the reason Jynneos is only in short supply is primarily because it was never intended to be used in a monkeypox outbreak. It was intended to be used as a secondary smallpox vaccine for immunocompromised populations, and ACAM 2000 was the real workhorse that the government stockpiled. There's also another second generation vaccine that's used in Japan. I've listed there for completion, but that's not available in the US. So you can use vaccine against smallpox in 2 ways. One is pre-exposure prophylaxis, just like we do for everybody else. You get a vaccine, you're protected. But you can use it also as post-exposure prophylaxis. Remember, I said this has an incubation period of 9 to 12 days. If you can get people vaccinated within day 4, you may be able to abort the entire infection from occurring. Or even if it's later, that infection is going to be less severe. So the vaccination is used in 2 different ways. However, it became very difficult to use it as post-exposure prophylaxis because that requires on people knowing all their contacts and being able to get to their contacts. So we shifted to vaccinating the at-risk population because contact tracing was just not good enough. And I'll talk about that in a second. So this was how we eradicated smallpox. We used a concept called ring vaccination, which meant we didn't vaccinate the entire world's population. We had a case, and then you would vaccinate all the individuals around that person, make a ring around them. That's ideally what you want to do with the pox virus, because that's what worked with smallpox. But with monkeypox, and it worked with monkeypox in prior cases where there was just a few cases, or the cases are related to animal exposure. But what's happened in this unique outbreak is that many of these individuals have multiple sexual contacts, some of them anonymous, and it becomes very, very hard to find contacts. So instead of using ring vaccination, we had to go to vaccinating the at-risk group. So again, why are we using Jynneos instead of ACAM 2000? And as I said earlier, monkeypox is not smallpox. It's not nearly as lethal, not nearly as transmissible, and we have the second generation vaccine. And a lot of people right now, because there's not enough Jynneos, are thinking, is the risk of higher side effects with ACAM 2000 tolerable versus a lower risk agent like monkeypox when a less reactogenic vaccine exists? So there is a debate going on about whether we should, because we have such a shortage, start using the first generation vaccine and select individuals. I'm someone who favors that, especially if, as you give people informed consent and you talk through that. If people want to get it, I think it's fine to give them ACAM 2000. It's available, but I think only one jurisdiction has requested it, so it hasn't really been used. But it wouldn't have been a question to use it before Jynneos. It's just because Jynneos is around, the risk-benefit calculation is favoring the safer vaccine or the less reactogenic vaccine. You probably have heard some of the dosing strategies that are going on. Initially, remember, Jynneos is a 2-dose vaccine. There was prioritization of first doses, just using their whole supply to get as many first doses into people as possible, and then catching up with second doses later. That's something that is being done. And now in the last several days, we've heard about intradermal administration. So just a little bit of immunology 101. If you inject something under the skin versus sub-Q or intramuscular, there are a lot more immune cells there. There's a lot more immune cells in the skin than in the subcutaneous tissue or in the muscle. So you can use less antigen, a lower dose vaccine, if you give it intradermally. This is what we do. This is what we did for the smallpox vaccine. This is also, there is a flu intradermal shot as well. Remember the PPD test you get for tuberculosis, that's also an intradermal administration. So this is something that is being used or trialed to be able to reduce the amount of vaccine you have to use by 1/5, by 5-fold, so a 5-fold dilution. So you're going to hear about this. There is some controversy because there's not a lot of data. I think it will work. I think we have to be innovative at this point because we don't have enough vaccine. So we'll see how this pans out. But there are, some questions. Some people have gotten the full dose, and now some people are going to get intradermal administration. There is some question about, is this a fair way to do it? But I think we're in a bad situation right now in terms of getting the 1.6 million people who need to be vaccinated. So there are a couple of antivirals to go over. The first one is TPOXX. So TPOXX was initially developed for smallpox. It's an oral formulation you give for 14 days. And it has animal data for monkeypox and some anecdotal report. And we are using it now in individuals who have high-risk conditions or those with severe pain, like those proctitis patients that we talked about. But the problem is there's a lot of paperwork because the way the FDA has made this happen, even though this is FDA approved, they're making you enroll your patient in a clinical trial to get it. And that means maybe 120 pages of paperwork, which is, I think, a very bad mistake by the federal government, because if you want to disincentivize people to prescribe an antiviral, you make them fill out a 120-page form. They're trying to streamline that, but it is still too much for people. I know that it wasn't a doctor that made that 120-page form. It had to have been some lawyer somewhere that put that together. It has minimal side effects. It also, some people have used it as post-exposure prophylaxis, at least in animal studies. So this is the main one that we're using. There is another antiviral called Tembexa or brincidofovir. It's the prodrug of cidofovir. So those of you who may have heard of cidofovir as an anti-CMV drug. It is very, very toxic, cidofovir. It causes renal failure. Brincidofovir is a liposomal form of that, so it's safer, but it does have a black box warning of increased mortality when used for longer durations. That probably doesn't apply to the use on monkeypox, but that is something that has precluded its use. It's not really around or available. Some people who work in transplant or pulmonary may have heard of this drug for adenovirus infections as well. And then there also is vaccinia immune globulin, which is what we would give to people who had severe reactions to the smallpox vaccine. There is some role for that as well. A baby that got infected or got exposed, it was a maternal mother, a pregnant mother got infected, and they gave prophylactically vaccinia immune globulin to the neonate. So those are the three main countermeasures that we have. But again, it's the onerous paperwork that's made this the use of TPOXX very difficult. So just to reinforce, you should have a low threshold though of getting that treatment for your immunocompromised people, a low threshold, anybody that has mental status disease. And then remember that pain shouldn't be ignored. That proctitis, you should treat it with TPOXX. You should go through the process or find someone to help you fill out those forms if you get a patient that has very severe pain. So the current outbreak, I think that the biggest lesson in this current outbreak is that the US is very bad at responding to infectious disease emergencies, because some of the same mistakes that occurred with COVID-19 occurred with monkeypox, in terms of that testing was very restricted and limited only to CDC affiliated labs, and only later was available at Quest and LabCorp. We've seen the vaccine, we've had doses expire in the stockpile, we've had doses sit in Denmark that hadn't been inspected by the FDA. We've talked about the 120 pages to give TPOXX, not very conducive to outbreak response. And remember, monkeypox should be something easy. It's not contagious. We've known about it since the 1950s. We have off-the-shelf vaccines, tests, and antivirals. This is something that shouldn't have gotten as bad as it did, which really tells me that there's a lot more work that we need to do to get able to respond. This outbreak that's occurred has probably been present maybe since the beginning of the year. And what we know is that there's been outbreaks going on, a long outbreak in Nigeria, and this probably has found itself in a social network. We know that men who have sex with men represent the predominant group that's getting infected, 99% in some studies, 95 to 99% in some studies. And I think what's happened is this virus, which can infect anybody, has gotten lucky. It basically found itself in a social sexual network and has been able to exploit that network effect. And we've probably seen introductions from Nigeria. There's probably more than one strain of this circulating, more than one introductions. And what's happening is because of this network effect, because there are raves, because people have multiple sexual partners, the virus has been able to spread farther and deeper than it ever has before. And I think this isn't anything new. So think about, if anybody's listening in South Florida, there's a meningococcal outbreak going on, and it's been going on for months in men who have sex with men in Florida. Not because it's targeting people because of their sexual orientation, it's exploiting a network effect, just like meningitis does in college campuses, or MRSA, more common in men who have sex with men. So that's what's happening here. It's a network effect. And it looks like, as I said, it's been here for some time because the mutations that are present are host mutations. There's an enzyme, this is getting a little technical, called APOBEC, which is an immune enzyme that will mutate viruses to make them less virulent. These strains of monkeypox have multiple mutations that have been caused by APOBEC. If you look at their character, that means that this has been here for some time. And what's happened is it was masquerading as a sexually transmitted infection. It was presenting not typically, not in people who had been to those endemic areas and these people, many of these people had predominant genital lesions, and they're presenting to STD clinics and they're getting diagnosed with other diseases. For example, in Montreal, they got diagnosed with chancroid. So if you've got something masquerading as a sexually transmitted infection, misdiagnosis, delayed diagnosis is going to be the rule. And then those people are going to spread it because they think they've gotten treated. They get their antibiotics for what they think is some other sexually transmitted infection, and they're contagious. So I think that explains what's happened with this outbreak. And I think we will see some spill into the outside of the risk group of men who have sex with men. But I don't think we'll see sustained transmission outside of that group because it's just not a very contagious virus. So I think that we have to keep, when you think about what's going to happen, a lot of this is going to be dependent on the federal government's response, and hopefully it's getting better. But keep the context of smallpox in mind. We're going to see people get immunity from infection, and that's likely to last several years, if not decades. And people are getting vaccine. So we're going to start to see some bending of the curve, I suspect, because people are getting immune from getting infected, people are getting vaccinated, and people's behavior is changing because they know this is out there. And we've already seen some of this happen in places like Montreal, where they've been responding earlier than we have. The big concern is the establishment, as I said, of an animal reservoir, not the person who infected their pet dog. That's not what I'm talking about. I'm talking about this getting into the population of squirrels or a population of rats that can't be controlled. That's where I think that the danger is, that this becomes endemic in that manner. I don't know if it will happen. I thought it would be more likely to happen in 2003 than in this outbreak, when it was actually in animals in 2003. So we'll see. The vaccine is really going to help with the trajectory. The more vaccine we have, the easier this is going to be to control. And hopefully this dilution in the intradermal administration works. And maybe there is some select use of ACAM 2000 for those individuals who want to get it. I think that's also going to be an increasing discussion in the future. There are a couple of unknown issues that I wanted to mention. There is some concern about asymptomatic or preclinical spread. There was one study that was done in Paris, where in an STI screening program, they were testing people for chlamydia and gonorrhea. There were some people who had no symptoms at all that had monkeypox DNA in their specimens, even though they had no symptoms at all. So that means that they had asymptomatic infection. Is that infectious virus? Is that transmissible? That's a question to be determined. However, I think even if it is present, it doesn't seem to be driving the outbreak, because it would be spreading much more extensively, much more spillover into outside of the risk group if it was spreading asymptomatically. And we also had heard about a person who had human monkeypox without viral prodrome or sexual exposure in California. This was a person at a concert, lots of skin-to-skin contact, even though it was with a t-shirt and shorts. Those are rare occurrences. The press is going to really harp on these types of issues for some time, but it's not. These are just unknown issues, I think, that are not driving it, but they're important academic questions to answer.
Wonderful.
So that's all I have. I hope that was good. I'm just trying to see what questions. I'm going to try. I'll handle some of the Q&A that I'm going to answer really quick, and then I'll turn. So how do we get monkeypox vaccine in Miami or South Florida? What I would say is look at the health department website. Miami and South Florida have vaccine clinics. Go to your local health department website. They will talk about where you can get the monkeypox vaccine. Smallpox vaccination during childhood. Is the immunity still viable for monkeypox? Probably not. Probably protection against severe disease, but probably not if it was done during childhood. And the amount of waning that's occurred and the fact that monkeypox is a distinct virus from smallpox, there probably is not much protection. And we know that people that have been vaccinated as a child against smallpox have gotten monkeypox. If one is exposed to monkeypox, what is the next step for the doctor or the contact? If you've had a significant exposure, the next step would be to get vaccinated. We are giving vaccine to close contacts of individuals. If we got smallpox, I answered that one. Okay, why COVID vaccine not given intradermally? We didn't need to do it intradermally. You probably could give COVID-19 vaccine. You can give any vaccine intradermally. It wasn't studied, and they went. It's hard. Remember, intradermal shots are harder to give. You have to be trained. You can't just. You have to make sure it's getting there. And we don't. We have to get all those TB nurses, the retired TB nurses, to teach people how to do it. So if you don't have to give it intradermally, you don't want to. What are the long-term repercussions of being infected with monkeypox with and without vaccination? Most people get better. Some people's rash can be scarring though. So that's an important thing to remember, that the rash can be severe and leave scarring, but we don't know any long-term sequelae other than the scarring. Does the monkeypox have transplacental transmission? It does. It does have transplacental transmission. You can do mother to fetus. Why is this more seen in homosexual groups? Okay. What's happened is that I think what's happened is it's exploiting a network effect. This could be something that it has to do with how many close contacts you have with close skin contact. And we know that we know, at least in many of the case patients, they've had multiple contacts, multiple sexual associated contacts, multiple close contacts over a short period of time, intimate contact where there's skin to skin rubbing. And I think it has to do with that, the network effect of how many partners they may have had versus other groups where that's not common, not as common. Okay, I've also seen, yeah, it's prevalent homosexual. Okay, yeah, so I think it's important. This is they said the fear is also a pandemic. It's important to remember that not every infectious disease has pandemic potential. I don't think monkeypox has pandemic potential because we have vaccines, because we know that immunity is long lasting, because we know that this is not very contagious, if at all, during its incubation period. So this is something that can be contained. So this is not pandemic, but that doesn't mean it's not important. We still have to control it. We can't let it spread, and we don't want another endemic infectious disease, even if it's not a pandemic.
Awesome.
Gosh, I'm trying to, so many, more and more and more. What testing do, okay. For women, again, it's you have to do lesions. You need to see skin lesions to do the test. Is it an STI? We don't quite know. There have been some papers that have shown the DNA of the virus in sexual fluids. I suspect that there probably is some sexual transmission in addition to skin to skin. All right, so I handled all those, so.
Fantastic, Amesh. I have a few other questions if you have time.
Yeah, I have a little bit, maybe 5 minutes I can go.
Oh, fantastic. Thank you. So, with the COVID, whatever we learned about 2.5 years ago, when the first news came about with the cruise ship and then the Seattle and then to the New York, we went through all of those things. Around that time, it felt like it was so distant. And then when it hit the whole country, then there is this, in addition to the pandemic, we had the panic endemic. Panic all around. So in this one, I mean, it doesn't look like the same amount of transmission, but I was very surprised to hear that from from the WHO when they made it into pandemic. It didn't have the same effect. Is it because it affected 70 countries all of a sudden? That's why they made it, even though the numbers were not that great?
So a couple of things. The WHO didn't declare this a pandemic. The WHO declared it a public health emergency of international concern. So that's a separate designation. So we've had public health emergencies of international concern for two pandemics, for H1N1 and for COVID, but we've had similar declarations for Ebola, for Zika, for polio. So it's not that. I think the issue was that we needed more coordination, we needed more resources put towards it, but it's not a pandemic. And remember, this is not a respiratory virus. It cannot spread like a respiratory virus. So that's why I think it's very limited in its ability to spread. It requires close contact.
I see. And how about this thing about people are getting panicked about, some of the people are panicked about, currency notes, transmission through currency notes from infected person to the other people. And then, multiple other scenarios that we can kind of think about and get panicked. But what is the reality on that?
So this is an important point. When you look at a textbook of all the ways a virus can spread, that doesn't mean that it's doing that in reality. It means, yes, there's some small possibility in some rare circumstance that can happen. But is that what's driving the outbreak? Look at the epidemiology. Look how if this was getting spread through dollar bills, imagine how many more people would be infected. How many people handle a dollar bill? So we know from epidemiology that it's not spreading that way, even if technically you could say, oh, it might be able to spread that way because it can be transferred from a person's hand or their skin to that. That's not how this is getting around. So I think this is very similar to COVID, where we had people washing their mail and washing all of their scrubbing their groceries. That's not how people are getting infected. So I think it's really important to say, just because a virus might in certain rare circumstances be able to transmit that way doesn't mean it actually will. I think we know from the epidemiology how people are getting infected.
Awesome. And then right now we have 3 weapons for this, mainly the vaccine as a pre-exposure prophylaxis, and then 2 medications available. It is still very hard. I haven't seen a case, but they described almost like 9,000 cases in the United States alone within the last month or 2. Is it?
Yeah, it's over 10,000 cases in the US.
10,000 cases. All right. Any other questions out there? And great lecture. Can we please get the recording of this session? Very useful. Thanks a lot. And
Amish, if you don't mind, can you also talk a little bit about the long-term effects of COVID? For example, the neuropsychiatric as well as other cardiovascular implications of long-term, if you don't mind.
Yeah, I can. So that's another 1-hour lecture to do. I think we still quite don't understand long COVID. We know that it's occurring. I think that first off, we have to agree on definitions. It's not well defined. We don't have good diagnostic criteria. And then you have to separate it from well-known clinical syndromes like post-ICU syndrome or PICS. That's very common in people who've been in the ICU, or even post-hospital syndrome. We know that people get readmitted if they've been in the hospital because of myriad reasons. So what you really want to focus in on are people who never had hospitalization for COVID. And look at the activities of daily living that have been disrupted. Not every type of symptom. We know that people can have a chronic cough for weeks after a viral illness. We want to really hone in on it. And I don't think we quite understand. There are some risk factors. We know it seems to be more common in females than males. We also know that those people may have higher viral loads. There also tends to be more pre-existing generalized anxiety disorder in those patients. But we don't have a good answer on all of this. And the objective findings in these patients are very hard to come by. Their blood work looks normal. Their echocardiograms look normal. It's all something that's very nebulous. Some people do have POTS syndrome, or postural orthostatic tachycardia syndrome. That's one objective finding that we see in some individuals. But I don't think we really know enough about this. And I would say if you have patients, there are many post-COVID clinics that are popping up, which are really useful. And I don't think we quite know what the long tail of this may be. I don't think it's as common as what people think it is. However, I still think it's a major problem. And even if it's a small percentage of a big number is still a big number.
So no biological marker at this time And there are some almost like 220 different symptoms that were described. And I think I saw a Lancet article saying that they are kind of grouping together into 13 segments and then coming up with the diagnosis. Is it 28 days post-infection or is 3 months? I know there is a confusion on that. Is there any clarity?
Usually 3 months is usually the number I use in my mind.
3 months. All right. And in your clinics or anywhere else, I mean, how is the workup as a pulmonologist? What we are doing is PFT to see if there is any air trapping. That is one of the commonest finding we are seeing on the PFT on these people when they have the shortness of breath or symptoms. And some of them are having organizing pneumonia, especially hospitalized patients. And we are giving steroids to those patients. And there is some data for that. In that field or in pulmonary or extrapulmonary symptoms wise, is there any data that you can share with us as far as treatment or management is concerned? Because this is a real thing. In a day, I see at least 1 or 2 post-COVID patients, and it is very confusing how to treat it. You alluded that there is no clinical definition, but meanwhile, any treatments that people are using that you know of?
None that I've seen. I've only seen some people with the postural. If they have POTS, you can use the compression stockings but I haven't seen any other. I still think we're just at the very beginning. I don't think we have enough information other than to treat these individuals symptomatically.
Awesome. And then the brain fog is one of the most common things. You know, I think we attribute every memory problem to brain fog, and people had the COVID. They're always saying that, okay, you know, I have the memory problem. And I don't think there is any data to treat or diagnose at this time, but there are some out of the, norm treatments available out there, but I think still a jury is not out. Yeah. Super. Thanks a lot again for your wonderful, wonderful presentation, and a couple of requests for, at least because of the monkeypox thing, your slides were very, very insightful. Is it possible for us to share, get some of this, at least onto the website? So at least 4 or 5 important slides, because rather than all the slides, if you can share, that would be good. I think a lot of people.
You guys should have my my slide deck already. So I sent it. So yeah, that's fine with me.
Awesome.
All right.
And then we would love to request you to come back for as and when it is needed for either COVID or, monkeypox or future, whatever is going to come in future. It looks like 2020, this century is more for viruses as, last century was for bacteria. Hope I'm wrong, but we would love to have you back again. I know there are too many topics here, but it was a wonderful presentation. Learned a lot. I have to look at your presentation 2-3 times, especially about the monkeypox. Wonderful presentation. Thank you again for coming in.
Thank you, Amish.
Right.
Hopefully we'll have you back for a panel discussion with other elite panelists we were talking about earlier in our communications. And we do have a virtual plaque to give you to invite you to become member of our distinguished speaker series. Vijaya, our office secretary, will display that just as a token of appreciation. We induct you into our distinguished speaker club, and we look forward to hearing from you more and more, many times. And also during our Pittsburgh meetings, also we'll hopefully get you back and have some more in-person discussions with you. Srini, you want to say anything?
Yeah. Thank you, Dr. Ramesh. It was a great presentation. Learned a lot from both from monkeypox as well as the COVID. This presentation will be available on the AAPI website for anybody to get the CME too by going there, and we'll have the slide deck available. Yeah. Thank you.
So we have over 160 people sign in, and also more people on Facebook also. Thank you, Amish. It was a good start for our CME series, and we'll have a monthly CME topics of importance like this. Again, thank you for hitting the ball out of the ballpark. Thank you again.
Thank you.
And thank you, Prasad, for doing a great job.
Thank you, Sinu.
Thank you, all the attendees, and
Have a
also
great weekend.
anybody in the New York area, please join the AAPI India Day Parade float tomorrow in Manhattan. So please come and join. We'll all be there also. and looking forward to that. Thank you, and please stay tuned for our next CME program next month, and Srini and I will be working on it along with our team. Thank you.
It's going to be a talk on cardiovascular. It's going to be a great talk about the Southeast Asians and the cardiovascular risk. Please tune in for the next CME activity. Have a great weekend.
Thank you. Bye. Stay safe, guys. Bye.